Welcome to Healthcare Logic for Growth, the weekly show where we talk life sciences and healthcare in general, things like clinical operations, research, commercial strategy, market analytics, and what it takes for anyone in healthcare to grow in a sustainable way. I'm Eric Marr, your host, the founder of Life Science Logic and a current Life Science Association board member. So whether you're building a biotech, running a rural hospital, leading a home health agency, or shaping healthcare policy, this show is for you. Hi, everyone, and welcome to today's episode titled RHTP in Texas, Inside the State with the Most Rural Hospitals on the Brink. 50. That's the number of rural hospitals in Texas that a leading healthcare advisory firm rates as vulnerable to closure. As of today, August 10th, 2026. Who knows how much that number will increase over the next 30, 60, 90 days and going forward. Not just struggling, not at risk in some abstract 5-year plan. These are hospitals teetering on the edge based on years of consecutive losses and collapsing revenue. This makes Texas the state with the most at-risk rural hospitals in the entire country, more than Kansas, Tennessee, or Georgia, to name a few. And right now, the federal government is delivering the single largest rural health investment in American history, $50 billion nationally over 5 years, through a program called the Rural Health Transformation Program, or RHTP for short. Texas's share is roughly $281 million a year under a state plan called Rural Texas Strong. And frankly, that's why we're starting a new series today, not a single episode, a series. Because RHTP is going to shape the commercial landscape for every small life science and healthcare company touching rural Texas for at least the next 5 years, if not longer. We're going to spend the next several episodes walking through the RHTP landscape piece by piece. The money, the fine print, the people, the trade-offs, the timeline, and eventually the playbook for earning a piece of it. So what does the landscape look like? Well, let's start with the baseline because you can't really understand what the RHTP is focused on without understanding how bad the snapshot already is. Nationally, more than 40% of rural hospitals are operating at a loss. 417 facilities are considered vulnerable to closure. In Texas specifically, it accounts for 50 of those vulnerable hospitals, the single largest concentration in the country. But there is an invisible crisis going on at the exact same time that we're having this discussion. Because before a hospital closes, there are services that just kind of quietly disappear. For example, Texas has the highest number of rural hospitals, 38, that have eliminated general surgery entirely. I mean, that's huge. Nearly 100 rural Texas hospitals no longer deliver babies. The average rural Texan now travels 59 miles to reach a referral center. In parts of West Texas, that number exceeds 100 miles. The Texas Hospital Association put it, plainly back in January of 2026, because rural hospitals are on what they call a constant and financially distressing high wire, battling closure risk, tight margins debt, and significant cuts to Medicaid. Now, obviously, this impacts everybody, the state of rural health, right? In this conversation, it's about Texas, but it's just in general. But let's talk about what the high wire looks like from the CEO's chair, because the macro numbers don't really tell the whole story. The Texas Organization of Rural and Community Hospitals Clinically Integrated Network, or TORCH-CIN, representing 45 rural and community hospitals across the state, recently notified United Healthcare that it plans to terminate all participation agreements. The reason? Alleged unsustainable reimbursement rates. And for those that are on this podcast for the first time, check out last week's podcast. We talked specifically about reimbursement rates. But according to Texas A&M Health, Rural and Community Health Institute, the data is staggering. Rural hospitals are paid up to 53% less than metropolitan hospitals for emergency department visits, and up to 44% less for maternity and OB delivery services. Paul Aslan, Torch CIN executive director, put it simply, his member hospitals have been absorbing these underpayments for more than a decade, while their costs have only increased. Quote, "Our hospitals are lifelines for the people they serve, many of whom have no other option within a reasonable distance. But we cannot continue operating under contract terms that make it financially impossible to keep the lights on. That's not a negotiation tactic. That's a survival instinct." Across the country, rural hospital leaders are making deliberate and frankly often painful decisions to keep things going. Their playbook offers a window into what Texas executives are thinking right now. Consider these examples. Rick Smith, CEO of Troy Regional Medical Center in Alabama, described a deliberate shift towards prioritizing high-demand core services, emergency care, inpatient medicine, outpatient diagnostics, while redesigning lower-volume services. The result? Improved operating margins and stabilized finances. Randall Dalby, CEO of Pinckneyville Community Hospital in Illinois, said his team emphasizes careful evaluation of each insurance contract to ensure profitability. Quote, "We are seeing more push to take it or leave it responses. We have to fight for a favorable contract." Justin Harris, CEO of Davies County Community Hospital in Indiana, actually entered a new management arrangement with the regional health system. Within roughly 6 months, the hospital shifted from losing millions each month to posting positive margins. Quote, "That takes partnership. That takes commitment to the community. That takes involvement from the community." And Eric Price, CFO of Schoolcraft Memorial Hospital, a 12-bed critical access hospital in Michigan, made a point that applies everywhere. Financial leadership demands physical presence. Quote, "If you're sitting at your desk, you're not rounding on the med-surg unit, checking in on your OR team, having conversations with physicians. You may be a little behind the power curve already." So what is RHTP? It's obviously the environment that we're all in, right? The Rural Health Transformation Program was created to direct $50 billion to states over 5 years, starting this year. How it's split: half the money is split equally across all states. The other half is awarded based on factors like rural population and need. Texas's plan is that the state's approval plan is called, obviously, Rural Texas Strong, and was formally approved in April of this year. The money? Well, Texas will receive roughly $281 million a year through 2030. That's $1.4 billion total. This makes Texas the single largest recipient, which tracks because it also has the most hospitals at risk. The plan is organized around 6 initiatives, including chronic disease prevention, direct payments to providers, consumer-facing technology, training in remote monitoring and AI tools, workforce recruitment, and a program called Make Rural Texans Healthy Again. Hospitals, rural health clinics, federally qualified health centers, EMS providers, and behavioral health organizations are all eligible to participate. As you know, on this podcast, we typically like to identify the potential myths or misconceptions, and especially with something that's as broad and impactful as RHTP. So let's clear a few things up. First, the myth is $281 million a year is a huge number. This basically solves the rural health hospital crisis in Texas. The reality, it doesn't. And the math tells you why. I mean, I understand exactly why people land with that thought. Compared to almost any other line item in a state budget, $281 million sounds enormous, but here's the reality check. Chartis reviewed cost data from over 2,000 rural hospitals. They found that a single 15% Medicaid cut, roughly the scale of cuts working through the system right now, would cost rural hospitals more than $1.8 billion, with a B, nationally. That single Medicaid cut is bigger than everything RHTP will deliver to Texas over the entire 5-year life of the program. And here's another catch. RHTP dollars aren't required to go to hospitals at all. States submit annual reports to CMS, but there's no mandate that a specific share must land with hospitals versus FQHCs, EMS, or wellness initiatives. By the way, here's what a few Texas CEOs are saying. Aaron Clevenger, CEO of Memorial Medical Center in Port Lavaca, Texas, a hospital high on the list of at-risk closure, testified at a public hearing. Her message to state officials was pretty direct and urgent. Quote, without direct financial support, all the planning in the world will not matter because there will be no hospital left to transform. Pretty strong words. Kurt Sunderman, CEO of Rice Medical Center, a 25-bed critical access hospital in Eagle Lake, Texas, raised a structural concern that should make every CEO stop and listen. He worries that when rural funding is distributed, it often doesn't reach the rural hospitals. Urban, suburban, and university systems capture those dollars first, and much of that funding disappears into overhead research or projects that never touch a rural patient. Quote, we're not asking for special treatment, only for resources originally intended for rural transformation. Again, Chartis, in its own review of the state applications, called these plans inspirational and aspirational, but flagged provisions that, in their words, may undermine the program's overall effectiveness and increase safety net instability. The honest read is this. RHTP is real money arriving at a genuinely dangerous situation. But it is not a rescue package sized to the actual scale of the problem. It's likely to treat the symptoms rather than cure the root causes. Now, that's not cynicism. That's just the math. I also get some version of this question constantly from operators and vendors serving rural Texas right now. One question has always been, RHT has been announced. Does this change anything for us this year? My honest answer to them is it changes the conversation you need to be having, but probably not your revenue model. Not quite yet, but close. A TrueBridge report surveying rural executives found that 41% believe it's too early to assess the net financial impact of RHTP funding, and 35% believe state Medicaid cuts will outpace RHTP subsidies over the 5-year period. Here's the operational reality. Budget period 1 has already been awarded, but CMS, or is in the process of being awarded, but CMS hasn't finalized the remaining budget years. Procurement processes are still standing up, and a lot of the money is flowing through grants that haven't fully opened. If your commercial plan for the back half of this year assumes RHTP dollars have already reached your customers, that's an assumption you might want to test, because any assumption to build a forecast needs to be confirmed, validated before that impacts the planning process, right, and how all this is going to work. So let's review some of the things we've chatted about, specifically 4 things before we get to the strategy. Number 1, Texas enters the RHTP era from the most precarious position of any state. 50 at-risk hospitals, the most service lines closures, and nearly 100 hospitals no longer delivering babies. This is a genuine emergency, right? We can all agree to that. Number 2, the CEO reality is that reimbursement is the true high wire. Rural hospitals are paid up to 53% less than metro hospitals for ED visits, and they're fighting insurance contracts just to keep the lights on. The playbook for survival involves right-sizing services, fighting for contracts, and building partnerships. Number 3, rural Texas strong is real money, right? $281 million a year, $1.4 billion over 5 years, organized around 6 solid initiatives. Get to know those initiatives. Number 4, the size of the number doesn't match the size of the problem. A single Medicaid cut costs more than the entire 5-year allocation, and Texas CEOs are already worried that the funding won't reach the hospitals that need it the most. This is meaningful help, but it is not a solution by itself. By the way, in next week's episode on Healthcare Logic for Growth, we'll go deeper into the math, specifically why $281 million a year won't close the margin gap, and what that means for your commercial strategy. Because funding is thin relative to the losses hospitals face. So what does that mean to those that support rural health hospitals through their products and services? That's episode number 2 of this 10-part series, which is next week. So as you know, we try to close out all of our episodes with a go-forward strategy. And remember, this is just if it helps. This is just if it applies to you, because sometimes it's just easier to edit than author. So instead of just leaving you with a blank page, we try to give you something to consider, but it always depends on your specific environment, your needs, and your resources. So here's a general go-forward strategy, 5 actions for this week that you can take. Number 1, get your own Texas exposure number this week. If you serve rural Texas, find out what percentage of your customer base sits in a county eligible for rural Texas Strong funding. It's tough to build a strategy around a program you haven't mapped against your own footprint. So make sure and do that. Number 2, bookmark the initiative list, not just the headline. Go find the 6 specific initiatives inside rural Texas Strong. Identify which ones, which products, services, whatever the case may be, you can realistically touch. The award announcement is not a strategy document. The initiative list is. All right. Number 3, separate announced from available. Budget period 1 is awarded, but procurement windows are still opening. Before you build a 2026 forecast, assuming dollars are flowing, confirm whether the funding mechanism is currently in force. Number 4, watch your customer's payer mix, not just the RHTP headline. A hospital absorbing Medicaid cuts while waiting on RHTP funding is a different conversation partner than the one that isn't. Know which one you're talking to. And if you're a CEO yourself, make sure you're fighting for every contract, not just waiting for grant dollars. Number 5, start following this series as a system, not a one-off. This is episode 1 of 10. The fine print in episode 3 and the playbook later in the series will matter more to your decisions than today's overview. So subscribe and come back. With that, take care, everybody. Thanks for spending time with me today on Healthcare Logic for Growth. If this episode brought you value, share it with someone in your network who's navigating their own commercial journey. I think they'll appreciate it. And if you have a healthcare-related topic you want me to tackle, leave me a note at eric@lifesciencelogic.com. Thanks again. I hope you'll join me on the next episode.